Good morning, everyone. Thanks, Dr. Vishali, Dr. Dogra, for giving me the chance to discuss a couple of interesting cases. I got 4 cases. Let's see how much can I cover. I do not have any financial disclosure with this presentation. Let's start with a case of a 60-year-old male who came from Assam to me in May 2017. He had a gradual progressive vision loss in his both eyes, which was more in the left eye, and he was diagnosed to have subretinal fluid in the left eye, and he had a history of taking intravitreal anti-VEGF injections in 2016, and his last injection was in May 2017, which was just a while before he saw me. If you look at the right eye, you see some changes at the macula, which are like pretty much could be just an RP changes. Sorry for the image quality. The left eye does show some amount of kind of a subretinal fluid, but clinically I could suspect some kind of a sclerosed vessel, which this is where I advise the patient for fluorescein. But look at the OCT where you can see that these OCT changes are showing some kind of RP changes over here with outer retinal damage. And we can see the left eye where the subretinal fluid is there. And if you look carefully, but still I was not convinced. Then if you look at the fluorescein, you will be able to see that there is a very typical signs of tributary retinal vein occlusion, the presence of ischemia and collateral, which actually gave a clear clue about the venous occlusion. The right eye did show some kind of a stellate hyperfluorescence, which was not leaking too much, so the things were going more in favor of CSR. If you look at the autofluorescence, you will see there is a hypo-autofluorescence in the right eye. The left eye does show hyper-autofluorescence. So if you really go look at the angiography, you are definitely sure that there is kind of a macular TRVO which was not responding. But what about the right eye? Right eye was showing some kind of a scarring, RP changes, RP atrophy, but I was not convinced with the left eye because there was a subretinal fluid, but there was no intraretinal edema, which is what you would suspect in case of venous occlusion if it was a recent loss. But let's look back at the autofluorescence, that why does autofluorescence show a hyper-autofluorescence? This is where I started suspecting there is some other disease as well. But as you know, that it is very difficult to make 2 diagnoses in a patient. So I asked for an EOG, which actually confirmed the diagnosis, presence of vitelliform dystrophy by reduced light rise. And I asked the patient to go bring his old records back, and he got it for the next visit. And if you see that the right eye in 2012 had a similar vitelliform lesion over here, which eventually died down and caused these hyper reflective deposits at the center. And the left eye, now you can see that this hyper-reflective area is not actually the SRF, but the empty cavity, which is where the vitelliform lesion is breaking up. And this was the most recent scan where you can see that this vitelliform lesion has broken and caused kind of a scarring, which you can suspect as CSCR, but the left eye, which we were suspecting as fluid, which was not actually the fluid, but the suggestive of vitelliform dystrophy with an old TRVO. Let's move on to the next case of a 36-year-old male. He came to me from Nagpur. His vision was 20/40, and his primary physician in Nagpur diagnosed him as CSCR because there was a presence of subretinal fluid as seen here, along with these fibrin deposits, which is what you would also do, suspect CSCR. The left eye was normal, and these were the pictures he got from him, and he was very reluctant to get a fluorescein. But if you look at the fluorescein, it definitely, this is a pretty late phase, but it does show there is a hyperfluorescence which is leaking in the late phases. If you look at the OCT which he got with him, there is a subretinal fluid, but I was still not convinced. I asked him to do, we have to do the OCT, and the OCT actually made the correct diagnosis of idiopathic CNVM as it is seen in this picture. So this case taught me that you really need to go through all the scans of the patient to look for any breach in the RP, which can be suggestive of idiopathic CNVM, especially in young patient where we are seeing with the SRF. Let's move on to the next case of a 73-year-old male who presented with a decreased vision for last 6 months, and he was advised to get an eccentric injection. He was coming from Calcutta. If you look at the right eye, it is very much in favor of wet AMD. You see these drusen, along with you have some exudation here and a presence of subretinal hemorrhage. The left eye does show some drusen, so things are pretty much under control. With 20/30, this patient is having a wet AMD. So these are the autofluorescence pictures, which again show a typical AMD picture, a hyper autofluorescence because of the lesion, and blocked autofluorescence or a hypoautofluorescence because of the subretinal hemorrhage. ICG was not very helpful, but this is pretty much because of the lot of exudation on top of it. We are not seeing much information from both the ICG and FFA. You can see this diffuse leakage, but this is like pretty much a wet AMD. If you look at the OCT was very interesting, where we can see the presence of a shrum lesion, that is subretinal hyperreflective material, along with these corrugations of the OCT and the multi-layering under the PED. The vertical scan also showed a PED, and this patient actually had an anti-VEGF injection, and you can see that pre-injection he was like this, and post-injection he came with a vision loss from 20/30 to 20/80, and there is an increase in the subretinal hemorrhage over here, and this is what brought my attention that what is the problem. If you look at the OCT, you will see that there is an increase in the PED height, but yes, there is some thinning of the choroid, the subretinal fluid is there. My fellow suggested that probably the disease is progressing, not responding to our treatment. But when we look at the autofluorescence, which actually brings a very important information, if you look at the pre-injection autofluorescence, you will see that this subretinal hemorrhage was corresponding to the hypoautofluorescence, what was seen there. But if you look at the post-injection autofluorescence, the hypoautofluorescence is much larger than the area of the subretinal hemorrhage on the both sides, and this is how we diagnose the patient to have a RP rip, which is called as double RP rip on both the sides, which is one of the very rare complication after anti-VEGF injection. So if I have time, I can move on with the last case of a 56-year-old male who presented to me with a blurring of vision for last 1 year, a high-profile patient. He was diagnosed to have CSR, and he came for the second opinion from Calcutta. And you can see that his right eye OCT is okay, but the left eye does show a subretinal fluid with some of the deposit, which I thought, yeah, probably this is a chronic CSCR. I got his imaging done, which is like pretty much okay. There are some deposits there. I was not suspecting a CSR CNVM, but that's more in favor of a chronic CSCR. As we can see, even the autofluorescence does show a hypochronic CSCR type of a picture. And the fluorescein angiography was very much in favor of CSCR, the typical chronic slow leaking lesions. The ICG of the right eye does show dilated choroidal vessels, along with a diffuse leakage, as you can see, which is again in favor of CSCR. Even the other eye also showed a diffuse hyperfluorescence in the late phases. So I went ahead and did a micropulse laser, which was 5% duty cycle with confluent laser burns. I saw him in 2 months, and there was no change on his OCT. As you can see, the subretinal fluid was persisting. The OCT angio did not show much changes. And I started him on eplerenone, and if you see that he comes back in 2 months' time, and again, there is no change with eplerenone. I'm sure that we have seen such cases, but look carefully, the vertical scan of this patient, which does show a dome which is actually switching the direction at this point of time, which was actually the cause of his vision loss and the fluid collection, not the CSCR. If you look at the left eye of his patient, this patient, you will see the vertical scan is characteristically showing a change in the thickness of the choroid, which is suggestive of a dome-shaped maculopathy. Thank you so much for your attention.